Good afternoon, friends. Uh, uh, Thank you, AIOC, for giving me this opportunity. I'm going to talk on taming the posterior polar cataract. So it is something which we come across every now and then, and every surgeon has to be very well aware of how to deal with this. So why? Because in PPC, most of the times the posterior capsule is weak or deficient. In a study conducted by Bobby Osher, the risk is as high as 1 in 3. Okay, so that's very high. 33% of the times your chances of getting PC rent, and in today's world that is just not acceptable. So, and it is very important that we differentiate it properly from a PSC. So in PPC, it's like a onion peel or bull's eye target kind of a picture. Whereas in case of PSC, it is a disc or a sheet, in the center of the posterior capsule. Pre-operative examination, careful slit lamp examination to differentiate between PSC and PPC. Rent, sometimes you can see on the fundal glow, and AIOC is very important to understand the integrity of the posterior capsule. So here is one picture where you can see the glow even before the cataract is removed. And on the other side, AIOC is showing that the PC is deficient. Sometimes PC is formed, but there is no gap between the cataract and the posterior capsule. Okay. Now here you can see that there is no gap between the cataract and the posterior capsule. There is a gap between the cataract and the posterior capsule. I will show you later on a case of PPC where there is no gap. Okay. Then preoperative consideration, operate as early as possible only when patient has visual disturbance. Don't disturb the eye, because if you get a PC rent and complications, we are going to have tough time. So whenever the patient starts complaining, after that don't wait, because harder cataract is more difficult to remove. Counseling is very, very important. We have to be very, very transparent. Later on it becomes very difficult to explain. You should have multiple IOLs ready and vitrectomy and retinal surgeon on call. Now the principle is very simple, that you have to be as gentle, as much gentle to the posterior capsule as possible. Otherwise, capsular access is very important because sometimes CCC is a savior, and you can either keep a 3-piece IOL in the bag with optic capture, or you can do a lot of other things. We have to use high density cohesive viscoelastic. So cohesive viscoelastic I want because I want the anterior chamber pressure to be maintained now. Whereas during phaco, I will have dispersive viscoelastic because I want to make a volume there, but I don't want to cause undue pressure on the posterior capsule. So this is one place where cohesive and dispersive we can use differently. The CCC has to be 5 mm and centric. Hydro procedures, hydro dissection, of course no. Hydro delineation, yes, if you're confident. Hydro delineation makes it the case very simple, and it separates the rest of the epinucleus from the rest of the capsule, and be gentle. Vigorous decompression of the bag has to be avoided, and that's why the hydro procedures have to be done very, very gradually, and nuclear rotation has to be avoided if you're not sure that you got the hydro delineation properly. Then phaco, do a slow phaco with low parameters, very low bottle height and flow rate. We have to avoid fluctuations in the anterior chamber. I've had a situation where PPC, I finished everything, and while hydrating the wound in the end, I got a PC rent. Luckily, by the time IOL was in place and nothing happened, there was no break to the anterior vitreous face, and the patient did well. And he was a celebrity. So sometimes you get into such a situation, So basically, you have to be very, very gentle with the all the maneuvers, including phaco. Emulsification has to be done without maneuvering, and friction to the PC has to be avoided. So either you can do peeling separation, okay, and use dispersive viscoelastic, the point which I already explained. Depulging the nucleus is the first step. Prolapsing the pieces of the nucleus or piecemeal. So there are multiple techniques. Sometimes you can prolapse like a pizza pie, you can prolapse it, or sometimes you can take it piecemeal by small pieces. And the removal of the opacity has to be left as early as possible. The upper half of the nucleus, or the cortex and the plate, has to be done either by manual separation or by visco separation. Irrigation aspiration, same principles again. Don't overfill the bag. And polishing, Dr. Nagwekar does polishing routinely, but I don't do it. I leave it for yak capsulotomy later on, because you're too scared that you will rupture the thing. Again, overinflation of the bag has to be avoided. IOL implantation with a snap. Okay, I have had a patient where toric, plate haptic and trifocal, and it just snapped and gave away. So after that, what I started doing, I first put the lens in the bag, in the in the AC, and gradually tuck both the pieces, loops inside, or whatever star. If it is a plate haptic, then one by one, all those 4. Then if there is a PC rend, first thing is that we have to do vitrectomy. If there is vitreous, just be very, very sure that your vitreous is removed. And it is possible sometimes to put a single piece lens in the bag if you manage to do CCC, posterior capsulorhexis, but many times the tear is oblong and you can't do it. But oblong tear has an advantage that you can put the lens across the oblong tears, and therefore many times you can still put the lens in the bag if you go very genuinely. And of course keep the 3-pins lens ready so that it is you can put it in the sulcus. Now this is video number 1 where I have taken the cataract piecemeal. It appeared to be a high grade cataract from the color. Now I have done hydro. See, what happened is that because of the high grade, I was not sure that hydro delineation has occurred properly. So I went piecemeal, taking the pieces one by one. And then at one particular point, I realized that over here, I realized that the plate is getting separated. So then I went for manual separation of the plate. I took my phaco probe out, and with the help of I'm still getting it piecemeal. Now once I realized, okay, now I went in with a dialer and separated it completely, and then it was easy to take this epinucleus out. Now we'll look at the Lensex or the Flax. Flax offers 3 advantages in PPC. Number 1 is that you can place the CCC. You get a time to place your CCC properly. Just imagine Sachin Tendulkar getting chance to think of the ball, plan in advance. Then he would have probably scored 1,000 centuries. Okay. Then second advantage is that that cylinder pattern, if you see in the center, it is very good in debulking the nucleus. And the third advantage is that pneumodissection is done, and therefore hydro procedures are many times not required. So let me forward it slightly. Yeah. Yeah, you see the air bubble being formed. Previously we were worried when a long time back we used to use lot of energy, but nowadays we are using only 1/3 of the energy as what we were doing in the beginning. So air bubbles are not too many, and you are very sure. Similarly, always keep a watch on whether there is at least one small hole in the anterior capsule where you are doing CCC, so that there is a chance for burping of the air out. Now this is another video I would like to show you. Just look at the hydrodissection, very gradually. Thanks to Dr. Nagwekar, I have taken the video from him. Hydrodelineation has been done very slowly, gently. Okay, but he was probably still not sure whether hydrodissection is, delineation has been done or not. So what he did repeated hydrodelineation. Now again, second time we are doing hydrodelineation. Okay. Now, because of this, it has become very easy to rotate the nucleus. Once you are sure, then you can rotate the nucleus. I'll forward it. and then take it piecemeal. And most important point to see is that you can take the now see the disc is still remaining, and it is being taken now gradually. This is perhaps the best demonstration that you could achieve hydrodelineation, and you could rotate the nucleus, and the disc is kept till the end. Okay, because of paucity of time, I deleted the video of posterior capsular polishing, and I left IOL management to the next speaker. Thank you.
Quick question. So when you have a posterior polar cataract, would you operate a patient much earlier, or a patient who develops a nuclear cataract or a round cataract? So would you recommend a very early surgery for these patients?
Usually, in my counseling, I don't give verdict. I leave it to the patient. So I tell him that if you do the cataract early, this is the benefit, and these are the complications you are likely to do. At the same time, it is not an emergency. Whatever you feel, you choose. So today many patients go for second opinion and all this. So we are giving them an option, and invariably, if you give proper options to the patient, they come back. So I will not take the call myself.
And suppose you land up with a rent during your nucleus management.
Yeah.
So what would you do? Do you go ahead with the phaco, or you try to get, let's say if it's a hard cataract, and you have a significant amount of your nuclear fragments which is still lying there?
Yeah,
So
see, that becomes a very, very difficult situation. What I will do is that I'll try to put, first of all, I will not withdraw the phaco probe immediately. From the other side, I'll try to put some visco, stop the irrigation, then go underneath the nucleus and put the heavy cohesive visco underneath, and I'll try to put the nucleus pieces in the angle shelf, and then take them one by one. Over here, if you want to be really very sure that you are not going to put a lens now, any premium IOL, then you can put 3-piece IOL in the bag and use that as a scaffolding. So the chances of the nucleus going down decrease.
for that, your anterior chamber has to be deep enough. If you have shallow anterior chambers, would you be?
Once you have got a PC rent, you are not that much concerned about the depth of the anterior. You can make it as deep as you want.
So your preferred surgical technique, Lensex versus the femto versus manual?
Any day,
phaco
Lensex is, it has got definite advantages.
in PPC.
Yeah. I'm talking about PPC. Huh.
Yeah. Thank you, sir.
Thank you.
Any other questions?
Can I add one point regarding hydrodissection and delineation? There is a Dr. Vasauda, and he has mentioned about inside out hydrodelineation. So you don't do any hydrodissection, but you start phaco, debulk the center. So by doing that, you are actually doing inside out hydrodelineation. And another point is that you can do separation mechanically by using a Sinskey hook instead of injecting fluid mechanically. These 2 points I just wanted to add.
Yeah, actually I covered those points, but what you said is correct. See, during the third video, which was given to me by Dr. Nagvekar, so
Actually, he was doing that.
Yeah, exactly. So what he's doing, he did first small hydrodelineation, very minimal, and as you are doing phaco, the fluid anyway seeps in.
Actually, it creates the wave and separates. And
Exactly.
another point which I wanted to add is, while doing irrigation and aspiration, the central plate you don't remove, you just pull it to the center from all the sides as if it is a flower petal. Don't remove everything, because if you pull it, then maybe the chance that you will avulse the whatever thing has happened at the posture. So you bring everything in the center as if a flower petal is there, and then remove gradually, and at the same time you put visco, so that there is a less chance of rupture of posterior capsule. That is how I do.
I would like
While
to
doing eye for cortex.
definitely this is one way, but sometimes what happens that when you are removing that disc of the PPC, you eat up the cortex, and you do not have any handle left to remove the PPC.
So don't eat all the cortex. You just bring it to the center, leave it.
If you bring it to the center,
from all 4 quadrants, you bring it to the center separately, so it looks like a flower.
My
with the
worry is
center
that
length.
if I eat it up, all four,
You don't
then
eat, na? You just pull it to the center and leave it there.
fine.
One more question, do we have time?
Yeah.
If you have a combination of small pupil with TPC,
I
Use
love.
iris hooks. Use
no,
iris hooks.
I use iRing. It's a device by some person in Delhi. He's a dealer. iRing. You can see videos. It's a green colored ring. The best part of this iRing is that you get more than 6 millimeter dilatation, and it is flexible. And you know, you look at it, you know immediately.
Gupta ring.
Gupta ring. Yeah,
It's
it's
very
fantastic.
bulky.
So
If AC is shallow, you cannot use it. It's bulky.
AC shallow, the server problem.
thank you.
Thanks.
Thank you.